Good morning, everybody. Welcome to today's webinar, STBBI Opt-out Testing in Provincial Correctional Settings. My name is Margaret Howarth-Brockman, and I am the Senior Program Manager at the National Collaborating Centre for Infectious Diseases, and I will be your moderator today. I would like to begin by acknowledging that NCCID is hosted by the University of Manitoba on Treaty 1, the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. We recognize the historical and present harms of colonization, and we strive for reconciliation with all our partners. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use by public health in planning and policy. We offer a range of knowledge translation and brokering resources, including webinars such as this one, podcasts, evidence reviews, discussions, gatherings, infographics, quick references, and so on. Before we begin, I'd like to mention some housekeeping items. We are clearly running this webinar through Zoom. If you have any problems with the Zoom platform, please email us at nccid@umanitoba.ca. The question and answer session today will be taking place using the QA tab at the bottom of your screen. We will try to answer as many questions as possible, but it's also possible that we might not get to all of them. You will also see that the chat tab has some extra communication for you. It's not enabled for participants, but there will be information that will be of value to you. And the recording of this webinar and presentation slides will be available shortly after the webinar at nccid.ca. Today's webinar on opt-out testing for sexually transmitted and blood-borne infections is part of a series of information and evidence translation we are offering on corrections. Through evidence reviews, podcasts, and webinars, we have been focusing on corrections facilities as public health sites. STBBIs are one group of infectious diseases that we are considering, and in particular, the movement of people in and out of incarceration, and the role that public health has in STBBI testing, treatment, and follow-up. Today's webinar will explore the evidence for STBBI care in correctionals and examine the development, implementation, and results of an opt-out testing program in Alberta. We have three speakers with us today. Dr. Rabia Ahmed is an associate professor in the Department of Medicine at the University of Alberta. She's a specialist in infectious diseases, and her clinical and academic focus is in developing novel models for health service delivery for marginalized and underserved populations, particularly in the areas of TB, tuberculosis, and STBBIs. Angela Drowdy is the Director of Correctional Health with Alberta Health Services. She's a nurse with over 30 years of clinical and operational leadership in various federal and provincial correctional health systems. Angela has led the implementation of the STBBI programs and in collaboration with provincial team partners, assisted with evaluation and best practice identification that best meets the needs of the incarcerated population. And thirdly, Jennifer Greatrix is the manager of the provincial STI program for Alberta Health Services. She has held various positions in the program, including STI clinic nurse, partner notification nurse, and epidemiologist, providing her with the opportunity to be involved in a variety of STBBI projects from surveillance to implementation science. So I'd like to welcome you all and thank you for joining us today. And I'll hand it over now to our speakers.
Good morning, everybody. As mentioned, we're going to be talking about our STBBI opt-out screening in our provincial correctional settings. In terms of
Margaret, did you want to make the slides? Move them ahead.
Chris is going to do that for you.
Thanks.
Next slide. Next one.
So in terms of disclosures, we just wanted to acknowledge that both myself and Jennifer Graytrix received grant funding for point of care testing for syphilis and HIV from CIHR, Center for Reach Nexus. Next slide, please. And we also wanted to provide our land acknowledgement. So we would like to recognize that our work takes place on historical and contemporary Indigenous lands, including the territories of Treaty 6, 7, and 8, and the homeland of the Métis. We also acknowledge that many Indigenous communities that have been forged in urban centers across Alberta. Next slide, please. So the objectives of our presentation today are to provide an overview of sexually transmitted and blood-borne infections in incarcerated populations in general, to provide the description and outcomes of opt-out STBBI testing in incarcerated populations within Alberta. We wanted to discuss with you the sustainability of our opt-out testing model, and then perhaps focus on what future opportunities this brings about. Next slide, please. So incarcerated populations worldwide, as well as within Canada specifically, have a higher burden of both physical and mental illness compared to the general population. And this is more so the case within females, who have a higher burden of both physical and mental illness compared not only to their female general population counterparts, but also to their male incarcerated counterparts. And perhaps the reason for this is related to the overrepresentation of the social determinants of health within this population. So the social determinants of health, as you may know, are well recognized to shape not only individual level health, but also community and population level health. And these include factors such as housing status, employment, working conditions, ethnicity, gender, social safety networks, social exclusion, as well as access to health services in general. And what we find is that incarcerated populations have an overrepresented in these social determinants of health. And therefore, they often have poor health status as they enter a correctional facility. Having said that, incarceration in itself can actually act as a social determinant, in that it often disrupts the social determinants even more so. Things such as housing, social exclusion, social safety networks are often fractured as individuals cycle from the community into a correctional facility. And it's also very important to note that many of the risk factors for incarceration are shared with the social determinants of health. And therefore, we create this vicious cycle between incarceration, poor health, and worsening social determinants of health. Next slide, please. However, on the flip side of that, incarceration does provide an incredible opportunity to access a large number of individuals that are typically hard to reach in the community. And we know from Canadian studies, as well as studies published in the worldwide literature, that individuals who have high rates of reincarceration simply do not access healthcare in the community. And therefore, they often enter the correctional system with many undiagnosed communicable diseases, as well as physical and mental health illness. And therefore, if we can improve access to health services during the incarceration period, we might be able to actually improve individual and community level health outcomes. Next slide, please. So the burden of STBBIs is, as you can imagine, overrepresented in the correctional system. And we know that individuals have higher rates of STBBIs compared to the general population. And again, this is more compared to their male counterparts. However, when we look at screening recommendations, they're quite variable. So Canadian specific guidelines were last published in 2002, and they recommended voluntary screening at admission. The US CDC had more specific recommendations, with their most recent being in 2010. And they recommended opt-out chlamydia and gonorrhea testing for all females under the age of 35 and males under the age of 30 at intake. They recommended universal opt-out HIV and Hep C testing, as well as opt-out syphilis testing based on correctional and regional rates. The World Health Organization also recommended universal HIV testing at intake, with evidence supporting increased effectiveness through opt-out screening. This is all within the recent or the more recent Pan-Canadian Framework for Action regarding STBBIs, which was released in 2018, which called for healthcare providers and leadership to improve access to testing, treatment, and care, and to provide innovative strategies for reaching those individuals that were hard to reach. Next slide, please. When we look specifically at STBBI testing within the correctional system in Canada, much of the emphasis has been placed on long-term incarceration. And in Canada, that's the federal system, where individuals are sentenced to 2 years plus a day. And this is because individuals are felt to be incarcerated for a long enough period of time such that they can be counseled, tested, treated, and followed up. However, having said that, the majority of individuals are held within the provincial system, which includes shorter sentences of 2 years less a day, or else they're remanded. However, by not providing standardized access to STBBI testing within the provincial system, we are missing a large volume of individuals who may not otherwise access health services once they're in the community. Next slide, please. So the reason that the testing has been a little bit less standardized in the provincial system is because it's a much more chaotic system, in that individuals are either there for an unknown length of time in the case of being remanded, or else if they're provincially sentenced, the sentences are often quite short. And therefore the challenge is being able to access individuals for counseling, complete testing, complete treatment, and complete the contact investigation. And within this, individuals are also dealing with transfers within the system. They might be transferred to the federal system, and they're dealing with court dates, and there's a lot of psychosocial stressors as they're often entering the correctional system at this time. So they're also dealing with withdrawal, pending court dates, care of family, financial issues, and those sorts of things. So perhaps STBBI testing is not at the forefront of their thoughts at the time. However, again, this is an incredible opportunity to reach individuals who may not access testing in the community. And we do know from studies published both nationally as well as internationally that incarcerated individuals are very interested in addressing all their health concerns during the incarceration period, and that they also feel that this is an incredible opportunity to address a lot of unmet health needs. Next slide. The other issue is the type of screening, or how the screening is implemented. So there are opt-in programs where an individual can self-request testing based on their own risk assessment or based on symptoms. And this is compared to opt-out testing, where all individuals are offered testing regardless of risk stratification or symptoms. However, within the opt-out model, timing becomes an issue. So do you do it at admission, during the incarceration, or at release? Next slide, please. So when we began to look at STBBIs within the correctional system within our province of Alberta, we began by reviewing our process. And period at 3 correctional facilities, being a youth center, a remand center, as well as a mixed sentenced and remand center. And at that time, we relied on an opt-in model. And what we found were incredibly high rates of all STBBIs. In fact, our rates were higher than that. Our rates for positivity, I should say, were higher than that at our local STI clinic, as well as rates published in the general international literature for positivity. And what we also found was that the proportion of people that were being tested were very low. This ranged from about 4.8% to 6.3% in the remand facility, and increased only to 12 to 16% in the youth facility. Next slide, please. So we felt that perhaps we could improve on our current model of testing, and we began to shift our focus to what was the evidence for opt-out screening. And what the literature suggests was a small but growing shift towards opt-out testing to really improve reaching individuals, as well as diagnosing and treating cases. So the majority of the literature published has been using a US lens. So Shake in 2015 looked at men and women incarcerated in Nebraska, and they compared opt-out to opt-in testing, and they found much higher rates of positivity using the opt-out model. Cole looked specifically at women, and they did a review of their opt-out screening, and again, they found higher rates compared to their historical positivity rate. Patella looked at men under the age of 35 in New York City, and they wanted to assess what the increase in their case positivity was, as well as how this contributed to overall rates within New York City. And they actually found a 10-fold increase of gonorrhea within the jail and a 1,636% increase in chlamydia cases diagnosed in the jail using the opt-out model. And this increased citywide rates of chlamydia in men by 59%. Franklin looked specifically at what the treatment outcomes were, and they noted that 63% of men leaving the facility were treated prior to release. Cavassari looked at both men and women in separate studies to determine what the optimal time of offering opt-out testing was. And they determined that early, so the date of admission, they were able to yield the highest consent rates for testing. So therefore, based on this, we felt that there was significant evidence within the published literature for implementing an opt-out program. And I'll now shift to Jennifer to tell you what we did.
Thank you. Next slide, please. All right, so at the same time as we completed our evaluation of our opt-in program, we were also seeing an outbreak starting in the Edmonton area of Alberta, where the rates of gonorrhea had increased to 130 per 100,000 population. Infectious syphilis was on the incline from 13 per 100,000 population, which was a doubling of the rates from the previous year. And the Provincial Chief Medical Officer of Health in April 2016 then declared a provincial outbreak. Just as a side note for all those on the call, these outbreaks are still ongoing. And despite COVID and the masks that Rabbi and I have, this remains a problem in our province. So as we're kind of looking at the outbreak and looking at outbreak management strategies, targeted and screening of known high-risk groups is definitely an outbreak management strategy. And at that time in the correctional facilities, we were using opt-in strategies, as Rabia had mentioned. And so we thought the shift to opt-out during the outbreak would be a great tool. We were very fortunate to have kind of a partnership with ourselves in the STI program and Rabia and the correctional health team. Diane Pine was the manager at that time for the facility and was a champion for us in believing in the program and offering that service to their patients. We're also very fortunate to have partner notification nurses that are located in each of the provincial correctional facilities that really helped with the partnerships in getting the program rolling. Next slide, please. So in March 2018, we implemented the opt-out screening program where universally all patients who are less than 35 years would be offered screening for chlamydia and gonorrhea, and that's urine-based NAT testing, syphilis and HIV serology in the short-term correctional facility. And this short-term correctional facility is a remand facility, and it's the largest in the province. We thought if we could get it working in the largest facility, then we would be able to figure out the nuts and bolts for rolling it out to other facilities across the province. So we really wanted to understand what the uptake was of the program at time of admission. We also wanted to understand what would be the reasons that people wouldn't complete testing, wouldn't consent to it, understand the positivity rates for STI and HIV testing, and then we wanted to ensure that after all this testing, we had the ability to make sure we had good treatment completion rates for everyone who tested positive. So next slide. So how it works is we thought through this process. We offered universal screening for those under 35 years. 35 years was chosen based on the opt-in rates where we found the highest rates were among the younger population. And then we had created an admission line list. So this was a sheet where the nurses at admission or the healthcare providers at admission would complete. So it was like a registry of everyone who was offered the program, whether they accepted or didn't accept. And the first things we wanted to consider was there any facility barriers to the program? So hard stops were security reasons where perhaps things were backing up at admissions and we needed patients flowing through the system. There was issues where maybe people were unable to consent based on their condition when they arrived. There was guardianship issues or any other conditions. Once the testing was offered to patients, then it was time for getting consent to test. So we explained the process and process of how to get tested, that we were offering it to everyone, which was a key in kind of reducing the stigma of STI testing. It also, universal screening reduces the whole need for a lengthy risk behavior questionnaire. So we needed it to be pretty quick in that admission setting. So we spoke about that. We also made sure to obtain contact information because with the remand facility, the turnover can be very short. So we were working on kind of a 5-day stay was how we based the program on. So got information on how to reach them out in the community. We collected information on why the patient didn't consent and looked at some of the common reasons that they came up with, which was they didn't perceive any risk or they were recently tested. They wanted to defer their testing till later in their stay. So at the time of admission, maybe late at night, they needed some rest and wanted to do it later. So we collected those on the admission list. For those who are consenting, we would then complete the requisition and obtain the samples at the time of admission. And one key factor was we used the medical director as the ordering provider so that we knew that all opt-out testing was ordered under that physician for evaluation purposes. And then we made sure that we had pathways developed for patient follow-up so that we ensured they got the treatment, the contact tracing and public health reporting within the facility, or if they were released, how we would do that into the community. Next slide. So in terms of the evaluation, we actually had 3 data sources that we pulled together. The admission line list was our kind of key enrollment log. We were able to obtain data extracts from the local laboratory so we could look at the positivity rates and testing volumes. And then CDOM database is the communicable disease outbreak management database that the province of Alberta uses. And that's where all positive STI labs and HIV are recorded. and the treatment information that goes with it. So linking the 3 data sources together, we were able to evaluate our outcomes. And we also looked at comparing our opt-out program to the opt-in testing that was also happening in the facility. So next slide. And so the results, we were very pleased and very happy to share with you. The uptake of opt-out screening was 96.7% of our admissions were offered opt-out testing. So that comes up to about 2,900 people who were offered screening during the 2-year time period. And only 69 of them were not able to be offered opt-out testing. And the main reason was what we called a hard stop or security issues. The next most common and fairly close was kind of consent and guardianship issues. So only 2.4% not offered. 32% of patients accepted screening at the time of admission, which I thought when the admission process was explained to me by the nurses in corrections and from Angela, with the chaos that can be happening all through the day and night, the fact that 1 in 3 people at that time in their life would agree to STI testing, to me, is actually astoundingly good and amazing. And the main reason for screening not being completed was that patients perceived no risk. And this is one, so 50% no perceived risk. And this is just one to keep your mind on, because we will look at that later in the slides, but it's where we could probably do some improvement work on helping people understand risk and kind of room for improvement. So next slide, please. In terms of the positivity results and case findings, so overall there was over 5,000 tests that were completed with a positivity rate of 19.3%. So more or less 1 in 5 tests we do are positive. New case finding rate was 11.5%. So not every positive result actually equals a new case. In particular, if you look at syphilis, where 1 in 3 people were testing positive on the syphilis EIA, that translated into a 7.3% of new cases being found. So with syphilis EIAs, of course, your blood can remain serofast, so it can be signs of previous treatment, new infection, and follow-up serology, which is still extremely important in the management of syphilis cases in the province, is getting those follow-up serologies so we can watch and see how people's dilutions are responding to treatment. In terms of treatment completion, overall it was 94%, and I'll highlight for syphilis, which is one of our priority, we prioritize syphilis, of course, 97.3% we have a treatment record on in the system. And we did find 1 new HIV case, and they were successfully linked to care. And then one of the big concerns, of course, was would we have enough time to treat them in the facility during their stay? And overall, 80% of the participants were treated in facility, which again is quite amazing for such a short stay with all the transfers in and out that Robbie had previously described. Next slide. So one of the things we wanted to do was compare our opt-out program to our opt-in to see what the benefit was. And I think really they're meant to be in conjunction. They're not meant to replace one another. Opt-out achieved significantly higher positivity rates than opt-in. So for chlamydia, that was 15% versus 9%. Gonorrhea was 11% versus 7%. The test positivity rates were nearly doubled for women than men, and women is a special target for us, in particular around syphilis and the risk of congenital syphilis. The one piece that the opt-out testing really helped us with was identifying the asymptomatic cases. So people with no symptoms, and that's where we really got the big increase in cases. So most of the cases, asymptomatic cases diagnosed in the facility, 72% were through opt-out screening. The one piece you'll notice is that opt-out screening did have a longer time to treatment than opt-in screening. So the median days to treatment for opt-out was 5 versus 3 for opt-in. And some of the reason for that can be when it's opt-in and you're going for symptoms, you can be treated syndromatically for that infection at the same time of visit. Whereas the asymptomatic ones are coming in be having that data, that collection date, and then it needs to turn around at the lab and it needs to come back for reporting to the facility, and then orders received by a treating provider. So I think that kind of makes sense for that piece. Next slide, please. In terms of the discussion, the testing non-completion was largely attributed to that self-perception of risk among patients. So it was really interesting because those who perceive themselves not to have any risk, we were able to look in the lab data, and 1 in 5 of those individuals tested positive for at least one STI HIV within 6 months from admission. So that's where we do have some work to do in terms of developing a script for patient education on the risk of STBBI acquisition. The delay in treatment for opt-out screening resulted in fewer cases being treated overall and within the facility. And again, that's related to that length of stay. But with the public health support of the STI program out in the community, so any case not treated in the facility would be referred to our program. And so we were able to increase that to 96% of cases being treated, and that rose to 99% for syphilis cases. Next slide, please. Okay, and this is short-term correctional facilities, as it are definitely important venues for STI HIV targeted screening strategies. There's a high turnover in the population, high turnover in the rates, but persistent risky sexual behavior in the post-release period. So what Rabia had mentioned before, some of the studies had looked at a decrease in community rates when you're able to treat people in facility as they're released back into that community. A large proportion of the incarcerated population is in short-term facilities, which we've mentioned earlier, and our studies had showed that high STI positivity rate as well. So these are just a comparison of the kind of 4 different programs. So opt-out is in the red box. That would be our program looking at the individual positivity rates. The opt-in comparison, which we've looked at before. The opt-in testing from our previous study, 2012 to 2015, you can see the shift that's happened just in terms of syphilis in particular. So it was 3.2% before the outbreak was declared, rising up to 30% and greater while we're in the midst of the outbreak. And then as Rabia had mentioned, the local STI clinic, looking at some of their information. I can assure you the local STI clinic numbers do look different currently, where they're sitting at about a 30% syphilis EIA positivity rate as well. Next slide. So I think now I'll be passing it over to Angela.
Thank you. Yes. So some of the things that we learned through the process as this program rolled out was that we really needed a champion in each of the facilities as we rolled it out provincially, particularly in Edmonton as the initial rollout. And if I can give you context, the population of the inmate patient population in Edmonton Remand Center is usually around 1,200 patients every day, and we usually get an average of about 50 admissions each day. So we really needed a champion in the facility to make sure that the education and the information was shared and oriented, and that the staff members were aware of the expectations on admission. Each site definitely has unique features. I mean, Edmonton is very, if you want to call a jail modern, it's very modern. And then we have some that were built in the early 1900s, and just even the setup of the facility looks way different in how our staff can access our patients and how they're actually moved through the admissions process at each of the center. COVID, wreaked havoc on all of us for sure. And so that was, definitely we're almost having to do I don't want to say a restart, but a reorientation and a refresh on it, because our numbers went way down during COVID, and we were just forced to really do the basic minimum care as we all were. The maintaining the training materials was really super important, and it still is, and it probably remains, I would say, is one of our main barriers to really reaching a larger number of our patient population. how we admit our patients into the facility, and Jennifer and Rabia both spoke about this, but I don't know if that I can adequately describe, well, because I've never been one, but I can only guess on the admission process, especially for somebody brand new to a correctional facility. Admissions is very, and I'm going to use the word traumatic because I don't think that's overemphasizing how that is for a brand new admission to a facility. The kind of the chaos and all the work that's done, not only from the correctional standpoint and our correctional colleagues, you know, literally strip searching and all of that stuff that gets taken away from them, their concerns with their family and all the other things that are happening, that just has from a new admission really a traumatic time for admissions into correctional facilities. So here we are coming in asking, hey, do you want to be tested for any sexually transmitted diseases? And it often is not the priority at that time. And it depends on, and I call it the cell of the staff member, and this is why the education and the script was so super important, but it still is areas for us to work on, is that how much time and how much energy and effort the staff put into that actual education in that moment, or making the effort, which we have seen grow throughout the facilities in the last couple of years, especially with COVID, is that they actually say, you know, this isn't a good place. It's not a good time to actually to have this discussion with the patient, and then they'll actually do a follow-up and defer the offer or defer the discussion with them once they get to the range and they're in a more settled place. The other thing that, you know, we didn't speak about too much is that the number of our patients that come into correctional facilities that are in withdrawal or detoxing is actually quite significant, and or in a mental health condition that's just not the best time for us to meet it. It's not our priority at that time, but we definitely do make efforts to defer and then go back once the patient is more settled and in a better place for us to offer that. But I would say that the training materials, the script, and the work that we do on our staff offering the testing or having that discussion with the patient is super important, and one that we'll continue to work on, because I think it's not only I know we can do better. And in terms of that, you know, no perceived risk and how the patient actually, you know, it's easy, and because I've been a correctional nurse myself, and it's easy to kind of scoot by that, and the patient says, yeah, no problem, and we just move on, rather than taking that time and putting that effort into having that discussion with the patient during that time to make sure that they understand what their risk actually is. So the ongoing communication, of course, is with the frontline staff constantly. We've been doing lots of work with our clinical nurse educators in terms of the education around the program and the reporting in particular. And that's a super important part. Rabia and Jennifer have done a fantastic job in the reporting that's provided to us monthly. Is there nice picture kind of trending reports that we go through, that I go through with my managers, that they then go through with their staff, and like lessons learned and how can we actually improve some of these stats, or do kudos on what it is that we're seeing. One of the things that I also, you know, need to mention is that all of our stats right now, we're not in an EMR yet, Connect Care in Alberta. For correctional health, we're in the last wave because nobody knows quite where to put us or how to reach us in those areas. But all of our tracking is manual, which is in sometimes barrier, sometimes an issue itself, because we don't always track or collect the work that actually is being done because of that manual component of it. But we are improving, and we seek to improve that each month that we go through the stats. Next slide. And I think, you know, for sure, one of the areas that we'll continue to address around that education, but also make sure that we're focusing on a culturally informed session. The stigma for sure remains around STI and HIV in many areas. We have a large disproportionate population of Indigenous patients in our correctional facilities that we know we can improve our cultural, you know, our cultural impact and our cultural assessments and work with our patients in those areas. Again, we're doing better, but we can improve our offering the multiple screens, the multiple offerings throughout the time with our education, whether it be on the range themselves once they've gone through admission, but also on discharge. And our focus on discharge is currently being highlighted as well. Earlier treatment orders for sure. We do common, frequent patient satisfaction surveys, and we do get lots of good results, not specific yet on the STBBI program, but it rolls up into some of our others, is our patients' perception and their experience on admission. And it does feed into a lot of the information that we do and how we're rolling out our programs. And certainly we can expand the model to other areas within our facility. So making sure that all of our staff are educated and have that ability to have that discussion at any time. Our points of contact are in some cases limited, as we heard at the beginning. The length of stay is so short. We have so short time period with these patients that if we can make sure we're having that discussion, or at least educate our staff to make sure they have that discussion, if we do, in the limited interactions that we have with them, to make sure that we highlight that as an educational opportunity. So, next slide. I think that's moving back to Robbie or Jennifer.
Okay, thank you. And maybe just on the other point, one future opportunity too is point of care testing. And this maybe is a bit of a teaser for another day, but the correctional facilities, again in Edmonton, were wonderful in hosting us to do a point of care dual HIV and syphilis validation study. And that was met with actually quite great success. And again, very shocked at, again, how high the positivity rate was coming out, but the ability to be able to provide immediate treatment to people for syphilis. So that study is just wrapping up and the analysis is being completed. And we've been accepted for a poster presentation at the AIDS 2022 conference in Montreal this year. So more to come on that topic, but a game changer in some ways for syphilis treatment on the spot. But in conclusion, the feasibility has been demonstrated for all STBBIs. We had a very high offer rate with low operational barriers. So that was wonderful. And we also, just to conclude the circle, had very high treatment rates by the facility staff. It says despite low uptake, but I'd actually edited that before, because I don't think that is low, 32%, as we've described what the admissions is like. But the overall facility testing increased overall by using both programs, which really allowed us to diagnose those asymptomatic individuals who may not have accessed testing in the community. And then, of course, there's limitations to the study, which includes the retrospective analysis of the routine data, as well as limited by that perception of risk among patients that we'll work on going forward. So next slide. We really wanted to just finish with an acknowledgement to the patients and the staff of the correctional health and STI services in the province. Of course, without patients being and the staff, both programs working towards providing that stigma-free care, this program wouldn't be successful as it was. On the next slide, I believe is just some references for you. Most of these slides, or a fair number of them, were put into a poster that was presented by our student Alexandra Riki, who we should give great credit to for doing the evaluation work for us. And coming in September 2022 will be the actual manuscript journal article published in the Journal of Correctional Health. And I think the next slide might be the conclusion. So thank you for your time and for coming to hear about our program.
Well, thank you very much, Jennifer and Rabia and Angela, for your excellent presentation. Really very interesting to hear about what you've accomplished in this program. Chris, with our slides, if you could just take this one down, because I don't want to distract from the topic at the moment. Thank you. I want to remind participants that you could enter your questions to us and to the speakers in the question and answer tab at the bottom of your screen, the Q&A. And there are a few questions there already, but I'm going to start with one of my own, which is what did you find, if at all, because I know it was a few years ago, of the likelihood of syndemic cases? So people who've come into incarceration with more than one STI when they arrive and they're admitted.
I don't know that we have the specific numbers to look at multiple positive testing for chlamydia, gonorrhea, and syphilis particularly together, but we do know that they very commonly do coexist generally within the Alberta population in general. And I think in particular with syphilis, we see a lot of co-infection with the other STIs. So we are definitely able to really impact individual level health by being able to treat the multiple co-infections at that time. And I think that one of the things that we should emphasize is that each encounter that the patient has with the healthcare provider offers an opportunity to discuss that risk and risk prevention and how to prevent this, ways to reduce your risk. And in our population in general, as I think that both Angela and Jennifer have commented on, that education piece is so important because there's a lot of myths out there about all these various STIs as well as HIV.
And maybe I'll just jump in because the one thing we often struggle with in the STI program is somebody will be tested for one STI and not for the others. But in our program for the opt-out testing, 97% of participants were tested for all 4 STBBIs. So it was really working well as we kind of think as a provincial program, how we could have a panel of testing. But of course, there's always that issue. And one other small limitation, well, not small, but a limitation to the study is we only used genital urine testing for gonorrhea and chlamydia. So again, that if we had been able to include extragenital testing, I mean, our positivity rate is actually an underestimation of what the true proportion would be. But we are not able to offer that at the time of admission.
Well, thanks. I can certainly appreciate that, but also know that the rate of syndemic, certainly in the prairie provinces, has been increasing, and perhaps for future research will uncover more. Thank you to Angela, who's answered a couple of questions already. So is the medical director part of the corrections or public health? And your answer was that the medical director is from corrections. And secondly, who provided the testing? And the testing was done by correctional nurses and staff directly. I'm just reading this in case somebody hasn't been able to follow what's happening in the Q&A tab. Another comment was, I tried to declare an outbreak in our corrections, but we had to deem that the transmission or acquisition had to have occurred inside the unit, so within corrections facility, as opposed to bringing it in from the community. Was that something that you had to contend with in terms of your navigations with the system staff and the administrators?
No, well, ours was, we were fortunate because the provincial chief medical officer of health declared a provincial outbreak. And so we were really looking at it as a broad population-based outbreak and where were specific targeted actions we could do to increase screening and testing among populations that might be underserved. And that kind of all went back to our epi of the outbreak and understanding who'd been impacted early on and then enhancing those measures for them. So trying to reduce those barriers. So yeah, fortunately, we weren't looking at a an institution or facility specific outbreak. It was provincial, and we were kind of going after all facilities. And corrections is just one of the arms of the outbreak plan.
Thanks, Jennifer. Another question raised is, do you think that the opt-out program could also be implemented for immunization and vaccination or other public health programs, I would say? Would it useful for that specific population or public health in general?
Absolutely. And we were working on this prior to COVID. And as Angela mentioned, the COVID pandemic was really a challenge to navigate within the correctional facilities everywhere, really. So we kind of fell off for a bit, but now, as Angela mentioned, that we're kind of looking at a reboot. We are hoping that we will be able to offer immunizations as well to this population. We know. So some of the work we had done prior to COVID did demonstrate in our literature review that this is a very under-immunized population in general, in terms of not only catching up on hepatitis B vaccines, but many others as well. And so hopefully we can refocus on that as well. But I think that many public health interventions can be linked to this particular intervention program.
Thank you. That really gets at a question I had, is what your opinion of corrections as a public health site means to you. So I think you've answered some of that. Sometimes follow through in the community has been quite a challenge in some jurisdictions. Can you talk a little bit more about what you've found for Alberta as people moved back out into community for follow through? You touched on that in some of your results.
Yeah, so we're very fortunate that we have a network of partner notification nurses throughout the province. And so any positive lab that comes from a correctional facility is flagged for us as a priority case to follow up on, because we know that they can be released into the community quickly. So the PNNs who are located in the correctional facilities, they'll receive those labs to work with the correction staff to try to triage their treatment prior to release. And then when someone is released into community, the folks at admission in the correctional facility has gotten that address for us. They fill in the notification of STI form that comes with us with that contact information. And then that investigation again will go out as a high priority to the nurses out in the community so that they can kind of have the best, newest contact information available to them to kind of not lose any time. And we also have the ability in Alberta, we have a test and treat model for the partner notification nurses, as well as an outreach team in the Edmonton zone who are able to go out into the community to community organizations or places where people might be to kind of help find people who may need some help in accessing care. So it's not perfect, but we do have a few strategies.
Well, thank you. That's great. And so somebody has been asking, can you share some of those program materials? Are they available through your website, or is that something that NCCID can help with dissemination of your scripts or presentations?
Yeah, we have.
Not to put you on the spot, but
I can chat with Angela, but we have some training slides that we've just developed as one of our future opportunities. And so that kind of gives you kind of the lay of the land, a little bit of the theory about why it's important to do it and how we've modeled it. But really, it's very, very simple because that admission time is so busy and we really wanted to create the least amount of work for the staff in that moment. And because it's universally offered, you don't have to have a large script. It's like, would you like STI testing? It's very simple in how it's delivered. But happy to share that with Angela's nod of approval there. We can send that to you.
Super, thank you. So I think we have time for one more question, which is, do you foresee any unintended consequences for using the opt-out model?
I mean, certainly, receiving results that are associated with stigma can be traumatic to individuals, particularly when they're in a time in their life where they're dealing with a lot of stressors in general. Just as Angela described, the event of being incarcerated is a very stressful and traumatic event. And having said that, being away from their typical social safety network, so not having family and friends to be able to support them through, a difficult diagnosis or a stigmatized diagnosis, obviously can escalate somebody's mental health stability. However, I think Angela could speak to how correctional nurses and the support that the patients receive from that staff can help to mitigate some of that anyways.
Yeah, for sure. And I mean, I think, and I just answered another question as well in there, but how the staff respond or do their assessment or communicate with the patient is probably the number one piece of either the patient's acceptance or not into what it is that we're looking for in all sorts of things, not just the STBBI. But so I just answered a question just with regards to the admissions portion in general. That can, if a really good thorough assessment and discussion and education opportunity is taken with that moment with that patient, it can take up to an hour for an admission. If somebody's wanting to get out of their shift and get the heck out of there, it can probably take 20 minutes and it's done. And the quality of that assessment is true. So the ramifications of that, any unintended consequences, is that we're not maybe offering a standardized service across until we get a stronger education component into our staff.
Super. Thank you both. Thank you, all of you, for your presentation and for your thorough answers to these questions. I'm sorry we didn't get to all of the questions this afternoon, but I hope that for those of you who have been part of our audience, that this has been useful to you. It is part of a series of projects that the National Collaborating Centre for Infectious Diseases has produced on corrections as public health sites, and we welcome your comments on that. And with that, I'll say thank you again, especially to Susie Taylor, our project manager, and Zishan Kader, who provides all the technical support to us. Thanks, everybody.
Thank you. Bye-bye.
Thank you.